Welcome to Doctors on Call. I'm Jenna Miller. Nearly 2 million Americans are diagnosed each year with cancer, a life-threatening disease that claims more than 600,000 lives annually. If you have cancer, you might see a doctor who specializes in radiation oncology. It's an area of medicine that uses radiation therapy, a treatment that focuses high energy waves on your body to kill cancer cells. Your doctor will decide if it's right for you based on the type and stage of your cancer, plus other health conditions you may have. Radiation oncology is our topic tonight on Doctors on Call with our guest, Dr. Shirley Butler of Hutchinson Regional Medical Center.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Hutchinson Regional Healthcare System. Our family caring for yours.
At Osborne County Memorial Hospital, our services range from clinic visits to inpatient and skilled care, but our specialty is you.
Your family is our family. The staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Russell Regional Hospital, experts, neighbors, friends.
Dr. Shirley Butler joined the Chalmers Cancer Center at Hutchinson Regional Medical Center as a radiation oncologist on September 1st. Dr. Butler, a 2012 summa cum laude graduate of the University of Michigan College of Engineering, enrolled the same year at the Wayne State University School of Medicine in Detroit, Michigan, graduating in 2016. In July 2016, she joined the Providence Hospital Transitional Year Program in Springfield, Michigan, for 1 year before relocating to Kansas City, Kansas for a 4-year residency program at the University of Kansas Health Center Department of Radiation Oncology. Dr. Butler is a member of the American Society for Radiation Oncology. She is a published writer and a frequent presenter within the medical community. Dr. Butler will head up a patient-centered practice. Give us a call at 800-337-4788 toll-free with your questions regarding radiation oncology. Today on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for joining us tonight, Dr. Shirley, and we will get started with some questions.
Thank you so much for having me.
Yeah, absolutely. First of all, tell me what a radiation oncologist is.
Yeah, so radiation oncology is a specialty where we use radiation therapy to treat a variety of medical conditions, most of which do revolve around cancer. So oncology is part of our name. And so I use high energy X-ray beams, such as light or other high energy beams, to break the DNA of cells, and that's how we can preferentially target those cancer cells that are really rapidly growing. And so I do treat sometimes non-malignant conditions, but most of my patients do have cancer.
Mm-hmm. Now, cancer often is treated through radiation therapy and also chemotherapy. Can you explain the difference between the two?
Oh, absolutely. So so we actually call the different treatment paradigms of radiation sort of a pyramid. So cancer, once it's diagnosed, the treatment options typically include surgery, which is one leg of the pyramid, systemic therapy, which is the other leg, and then radiation therapy is the third leg. And so surgery actually goes in, it's a surgery, so they go in and take the tumor out. Medical oncology typically is more systemic, so it goes throughout the whole body. So chemotherapy is an aspect of medical oncology, so chemotherapy goes throughout the whole body, and it's cytotoxic, meaning it kills the cancer cells but can affect cells throughout the whole body. Radiation therapy, on the other hand, is a little more targeted, so we are very specific in the area that we're treating, and and the planning process is actually very important to us because we want to make sure that we're only treating the area that we want to treat. So whereas chemotherapy goes throughout the whole body, radiation is targeted to just the one area. For example, for breast cancer patients after surgery, if they have lumpectomy, then we'll treat the whole breast, and so my treatment target time is that breast that had the cancer. And then I do everything I can to avoid the heart, the lungs, the other breast, so that we're very targeted to just that area.
Do you sometimes treat patients that are only doing radiation therapy, or do they usually do both?
So we can treat patients with just radiation, and radiation is curative for certain early stage cancers. So for example, early stage larynx cancer, we do offer a definitive treatment option with radiation, where our hope is to cure the cancer and also preserve speech at that point. And then for prostate cancer as well, for again more intermediate earlier stage, we can treat with just radiation to cure the cancer, and for high-risk prostate cancer, we would use radiation in addition to hormone therapy like Lupron to be able to cure the cancer.
Interesting. We mentioned in the intro that the Chalmers Cancer Center. Can you tell us what that is and if it's a part of Hutchinson Regional Healthcare System?
So Chalmers Cancer Center is part of Hutchinson Regional Medical Center. We are an outpatient clinic, so we're in the realm of the hospital, we're physically separated. And so it is we are outpatient, and we do have our own parking lot and everything, so it's very convenient to come and go through us. You don't have to go through the whole hospital or anything. My CT scanner for radiation planning and my radiation oncology treatment machines are in the clinic. So everything that we do for radiation planning and delivery is in-house.
Okay, and who makes up a radiation oncology team?
Yeah, that's a great question. So it is definitely multifaceted. I have a nurse who will do our intake in terms of when I see the patient and helping to take care of the patient throughout treatment. I do have a nurse practitioner. We have a dosimetrist whose only job is to make sure that when I plan a radiation treatment, that we get as much of the prescription dose to where I'm aiming for as possible, and as little dose to the heart, the lungs, to the normal tissue where I'm trying not to avoid as possible. So we're trying to avoid all those structures. And so when I do the treatment planning, we get a CT scan first. So I'm drawing out where the area that we're treating is, so tumor or whatever the target is, and I draw out the normal structures. For example, for breast cancer, I draw out the heart, the lungs, the other breast, so that we're trying to avoid those. And my dosimetrist does, her job is to make sure that I get a great plan for treating the cancer, but also avoiding those normal structures. And then we have radiation therapists whose role is to deliver the actual treatment with the machine. And so they're a vital part of, again, our cancer treatment, because they're the ones that are actually delivering the treatments Monday through Friday, every day for the patients. I have a physicist who's in charge of making sure that the plans are very safe for delivery. So he does a lot of quality assurance and making sure that our machines are very top notch. And so all of us work well together in terms of making sure that we have a very safe and effective plan for patients. Excellent.
What is the difference between a radiologist and a radiation oncologist?
Yeah, so a radiologist is specializing in imaging, and so like MRI, CT scans, PET scans. When patients get those studies, the radiologists are the physicians who read those scans and give a report and determine what the findings are on those scans. Radiation oncology is a therapeutic, so we are a treatment specialty. So we use radiation in all of its forms to treat patients mostly with cancer, but sometimes with other conditions as well.
You had mentioned safety. I think sometimes the word radiation, people are trying to avoid radiation, and it's kind of a scary word. Explain that and how you are safe with it.
Oh, absolutely. So I think radiation does have a poor track record over the last probably several decades in terms of like nuclear bombs and all of these things that we hear, right? We hear in as we're going through our lives, we hear in history class, all of that. And so radiation can have side effects. if it's delivered to certain structures. And so from our standpoint, we're using radiation to break the DNA of cells, especially cancer cells, and we're doing it in a very targeted fashion so that we are being very specific in how we're treating. So if we just blast the whole body, we would definitely have a lot of side effects. And so that's why we're very specific in making sure that our radiation is only going to those structures that we're trying to get radiation to, and avoiding the normal structures as best as we can so that we can give a very safe plan. And so toxicity from radiation, again, is very specific to the area that we're treating. So it's very uncommon that we would treat a large area. We're usually pretty targeted in a smaller area. So for example, if a patient is getting breast radiation after a lumpectomy, then the skin can get a little pink sometimes. It can get sort of like a sunburn. I guess and a lot of these side effects really depends on exactly how much we're giving and the specific entities. But we do avoid the heart, the lungs, and the other breast so that we're trying to avoid toxicity in those areas.
Now, do you ever find that you've radiated maybe too much and then you have to back off?
So all of our treatments are typically they're designed in entirety. So we don't. So we know going forward with the plan how much we're going to give. So we don't really stop midway through intentionally unless a patient is just not able to tolerate it. So my clinic is very evidence-based. All of the plans I give are based off of research, decades of research with patients, with hundreds of thousands of patients really in the entirety in terms of medical research, and most of the studies do have hundreds, and thousands of patients. And so, and actually what's really, I think, useful for patients to know as well is that the National Comprehensive Cancer Network, NCCN.org, it's an entity made of thousands of physicians looking at data from hundreds of thousands of patients to see what type of cancer treatment is best for each type of cancer, and that's open to everyone. So, so I always recommend my patients to make a free account on the NCCN.org and see for their specific cancer what the best recommended treatment is, so that they are a part of their cancer care team. Because I do want my patients to advocate for themselves and for their loved ones, because at the end of the day we want to make sure that everyone's getting the most comfortable treatment that they can.
That's very important, I think. That's great to hear. We want to remind our viewers that we are talking to Dr. Shirley Butler today from Hutchinson Regional Medical Center. We are talking about radiation oncology. Give us a call at 800-337-4788 if you have a question for her. I'd like to talk a little bit more about the machines that are used for radiation therapy. Can you explain those?
Absolutely. So there are several different types of radiation. So when we say radiation, our goal is to, again, damage the DNA so that the cancer cells die. And how we do that, it's pretty multifaceted. So most radiation machines are called linear accelerators. So they accelerate electrons that then hit a target to make photons. And it's the photons that actually do the damage. And so I have two machines in Chalmers that do that. One's the tomotherapy unit and one's the true beam. They're just pretty typical radiation machines. Another way that we can deliver radiation is actually through the body. So for patients with thyroid cancer, we do radioactive iodine, and that's given in a pill form where it's tagged. So it's a radioactive activity source that's tagged to iodine that then gets localized to any thyroid tissue to be able to kill those cells. And so that actually goes throughout the whole body. And so we always say for those patients to stay away from pregnant women, young children, things like that. And there's actually a very specific set of instructions we give depending on what the dose we are using. For most of our external radiation, for the linear accelerator machines that we use, we don't have any recommendations in terms of caution, because as soon as the machine's off for the external radiation, then there's no more radiation that's being given. So patients who just get external radiation treatments from a linear accelerator, then they are never radioactive at all. As long as the machine's off, there's no more radiation in their body. And so there's no restrictions in terms of like where they go, who they are with, things like that. There are certain internal radiation sources that we use. So for example, for prostate cancer, and I don't do this, but at University of Kansas, they do what's called brachytherapy for prostate cancer, and they insert radioactive seeds into the prostate that then can kill the cancer from the inside out. And that is a treatment for prostate cancer. For certain gynecologic cancers, we do have also, it's called brachytherapy from an internal source, but that's a source that goes through a machine into catheters that are placed into the body. And that is actually something that I don't do either, because we just don't really have the patient volume to support a program like that. And those are mainly in bigger academic centers.
How long does a cancer patient typically have to come in to receive therapy?
Yeah, so that's a great question. It really depends on the type of cancer we're treating, what exactly our goals of treatment are. So for patients who have metastatic cancer, oftentimes they have symptoms like pain or other issues from the local effects of that cancer. And so for bone metastases, we can give just one shot of radiation that really helps with their pain. So we can do as little as one treatment. And for brain too, for brain metastases, if we're treating a stereotactic high dose course, then we would just do just one treatment. That's the shortest. On the other end, for certain types of prostate cancers or other cancers where we're having to give a much smaller dose per treatment, then we can go all the way up to 8 or 9 weeks of Monday through Friday treatment. So anywhere between one treatment to 9 weeks.
Okay. Does a radiation oncologist perform surgery?
So not so much surgery. I did allude earlier to the brachytherapy portion, so that's internal radiation. And so some of those procedures are done in the OR, but they're not surgical in that we don't make incisions and we don't really cut anything. But for example, for prostate brachytherapy, we would do insert needles that would put the radioactive seeds into the prostate. So some things are done in the OR, but not necessarily the same way that we would think with surgery.
Sure. What are some potential cancer symptoms for a woman that should be checked out by a doctor?
Yeah, so I think the most important thing for just all of us really to be aware of is that the earlier the cancer is caught, the easier it is to treat and to cure. So symptom-wise, breast lumps, bumps, things like that are very important to get checked out because that could be a sign of cancer. Any breast changes could be vaginal bleeding is a not uncommon symptom for uterine cancer. And just anything that's really out of the ordinary for that individual. And I really think beyond the just symptom-wise, the most important thing is to make sure that we're following with our primary care physicians and getting the necessary screening tests, because by the time a lot of these cancers are showing symptoms, then they're at a stage where it's really difficult, if not impossible, to cure. And so the earlier we get these cancers, the easier it is and the more likely it is to be cured. So for example, for breast mammograms, I'm a huge proponent because most of my patients that have early stage breast cancer were caught on mammogram, and so they were just not able to feel it, but we're able to cure them because the mammogram were able to catch it. That's very important.
Sure. And what about men? What are some early signs for them? Yeah,
so for men as well, so prostate cancer is probably the most common type of cancer for men, and so a lot of that is unfortunately asymptomatic, but if they have urinary issues, rectal bleeding for rectal cancer will sometimes happen, or anal cancer. But for men especially, I think what's actually more important than looking at symptoms is just making sure that they do the rectal exams with their primary care physicians, because again, the earlier we catch these things, the better, and then PSA testing as well, just to make sure that the PSAs are not going higher than we would expect, because that's again a sign that there could be something going on, and the earlier that we catch these, the much easier it is to cure them.
So when you have a patient come in, they've had all the tests, and it comes back that it is cancer, then what?
So it really depends on the type of cancer. So for breast cancer, which is again the most common for women, then so what typically happens is they do a mammogram and they see a speculated mass or something that's abnormal. And then we would get additional images and possibly an ultrasound to be able to localize it and then biopsy it. At that point, depending on the how extensive it is, we would stage the axilla to see if there's any lymph nodes. Sometimes we get MRI to make sure that we are not dealing with anything more and that we are able to offer the best surgery for that, because a surgery is absolutely necessary for breast cancer. And then afterwards, depending on what we find at the time of surgery, then we talk about radiation and or chemotherapy or hormone therapy. And so a lot of it really depends on the type and the extent of the cancer. But for most of these cancers, again, the medical oncologist, radiation oncologist, and the surgeon will work cohesively to get the best treatment options.
Sure. And when they are given that diagnosis, I know it's very emotional for the family. Talk about your protocol and how you handle that side of things.
Yeah, so I actually, so my philosophy is person-centered care. Because I know the whole patient-centered care is a very common thing that is pervading into medical societies and all of that. But I actually think that the person is very important, because we're not just our diagnosis, we're the entirety of our personalities, our family, our support system, all of that. And so for me, I am very involved in the personal aspect and making sure that my patients are comfortable and that they're understanding their diagnosis. So I spend a lot of time explaining what the cancer is, what the options are, and just making sure that they have the support system around them and they're really able to understand everything that we're explaining and have the resources to be able to treat their cancers. And so I always again talk about the national guidelines, because I do want to make sure that all of our patients are able to advocate for themselves and their families, because I think that's very important. And knowing exactly what to expect and what the best options are, I think is very important. So person-centered care is definitely my philosophy.
That sounds wonderful. How do you immobilize patients for treatment?
Yeah, so like we talked about, radiation is very localized and specific to the area that we're treating. And so depending on the area that we're treating, we have different immobilization devices. So for example, if we're treating a breast cancer patient, which I use that example a lot because we see so many, we have a specific breast board where our patients have their arms up and are grabbing onto a portion of the breast board so that we're able to immobilize the body and treat that way. For our head and neck patients, we actually make a mask where it starts off as a soft structure, and we apply it to the face and the neck, and it hardens into a mask specifically for that patient, and that's how we make sure that they are not moving during radiation. We do have specific beanbag-like types of devices for hips for patients where we're treating the pelvis, and so just depending on where we're treating, we have very specific devices for those areas.
Sure. What is the success rate of radiation therapy?
Yeah, so a lot of this also depends on exactly the type and the stage of cancer. So for patients who have early stage breast cancer after surgery and after the appropriate systemic therapy, for very early stage breast cancers that are hormone positive, after surgery and systemic therapy and radiation, the chance of cure is well over 90%. So great chances. Again, for prostate cancers who are early stage that we're treating, even with just radiation alone, very high chances of cure rate. On the other spectrum, for patients who have glioblastomas, which are very aggressive brain cancers, unfortunately, most patients do recur, and so prognosis is very poor for those patients. So it's really a matter of the type of cancer and the stage of cancer, and the earlier we catch cancer, the more curable they are.
Okay, we just have a few seconds left. Maybe give some advice on how a person can feel better during their cancer treatment.
Yeah, absolutely. And I think for patients, a lot of it is just making sure that that they're comfortable with their care team, and making sure they're surrounding them with people who are very supportive, because a lot of therapy, it's not just the treatment aspect of it, it's getting through, it's not just the cancer aspect, it's getting through treatment as well. So having a support system is very important. Eating healthy is also very important, and just knowing that it's okay to ask for help, I think, because a lot of our patients, again, they're used to doing everything for themselves, but at this stage, it's very important to know that there are people that are there for them.
Excellent. Wonderful. Thank you so much for joining us. We got through a lot tonight. Our thanks goes out to Dr. Shirley Butler. On our next Doctors on Call, we'll be discussing fitness and nutrition. You can email questions to our next program at doctors@shptv.org. Thank you for joining us. For Doctors on Call, I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from At Blue Cross Blue Shield of Kansas. We're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Hutchinson Regional Healthcare System. Our family caring for yours.
At Osborne County Memorial Hospital, our services range from clinic visits to inpatient and skilled care, but our specialty is you.
Your family is our family. The staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Russell Regional Hospital, experts, neighbors, friends.